Yeah.
Yes. No.
All right. Let's go, Sam. Start.
Bismillah. A 78-year-old woman presents with right hemispheric transient ischemic attack and ipsilateral carotid stenosis of 80% by CT angiogram. She has pulmonary hypertension and anatomically high carotid bifurcation. She is scheduled for TCAR on the morning of the procedure. The anesthesiologist notes that the patient forgot to fill her prescription for Clopidogrel preoperatively and has never taken Clopidogrel. The most appropriate management is, so she's old lady, I think she's high risk for GA, and anatomically she's not fit for surgical option open. And the problem, she didn't take antiplatelet before surgery.
Okay. So this is really an issue we see it many times. I think it's a very important issue. Is it how important to be antiplatelets, you know? I mean, it's very important to antiplatelets to start ahead of time, especially Plavix. So Plavix doesn't work right away. Aspirin it works, but Plavix takes a couple of days to work.
Yeah.
So this is a problem. So always, the reason why we tell the patient always to start ahead of time. You know, if they come for some reason did not, usually we load them in the day of the surgery. You know, we load, you know, especially like the cardiac, they give like 300 of Plavix and give an aspirin. They give like 150. So they give very high dose to load the patients. In peripheral, sometimes we do that. So the problem now is this patient, she didn't take any aspirin. I'm going to put a carotid stent. So the question is that, what should we do? Should we cancel surgery, give a load with a, you know, with a Clopidogrel, or convert it to the open? So you see, carotid stent different from, you know, from coronary or lower extremities because, you know, thrombosis is a disaster, you know.
Yeah.
And in all trials, when they said it worked very nice, they are very restricted with the antiplatelets that they have to start before. This is a part of the trials, you know. So if you decide to do anything different, then you get out of the trials, you know, we don't know what the outcome could be. So this is a problem, you know. So even, you know, from the clinical standpoint, you say, okay, I can give a load at the same day of surgery, but the trial did not say that, you know. So you have to, so if something happened, if she got stroke or something like that, be very hard to defend yourself because you went out of the protocol. This is the first thing. The second thing also, she's symptomatic. And if you wait, what if she get another attack of, you know, TIAs or stroke? It's another problem. So you have to look at that also. Okay?
Yes.
So let's see what is the options you have.
Okay. Postpone the operation and begin dual antiplatelet therapy with the plan to proceed in 1 week.
Okay.
Or administer a 650 milligram of aspirin suppository and proceed with the procedure. Perform a transfemoral.
Sam, so the first one, what do you think, is right or wrong, or it's possible?
Yeah, I think it's one of the. That's why I want to go through the answers.
So
yeah, maybe we'll choose it. But
yeah,
the other.
It could be yes or no. I mean, it could be. It's not obvious wrong. Could be right or could be wrong. So this is one put on the side.
Yeah.
But we eliminate the wrong one. So let's go to the B. It's wrong or could be also put on the side.
No. 650. It's a big dose, and suppository. I'm not sure if it is working like oral or not.
Correct. So it doesn't work like that. And second thing, the problem is the Plavix, not the aspirin here.
Yes.
So this is wrong.
Yeah.
Okay, let's go next one.
Perform a transfemoral carotid stent with distal embolic protection. It's the same problem. If you cannot do TCAR, which is easier for the patient, I think also you cannot do transfemoral.
In general, transfemoral is not recommended for 70 and above. And the patient, this one 78. That's why they decided to do TCAR. Because the CRISP trial showed that if you do it for 70 and above, chance of stroke is higher because the disease arch and autotroicity, you know. So this one, I think, is out of question also, you know. Okay.
Okay. Load the patient with 150 milligram of Clopidogrel and proceed as planned. Yeah, I mean, yeah, it might be, but maybe it's unsafe لأنه المريض ما أخذ من أول يعني she didn't start from the beginning.
Right.
Maybe it's unsafe because the Clopidogrel, as you mentioned, it's will not the effect will not start immediately. Yes.
Okay.
Not like aspirin. So I will not choose it also. Convert the case to carotid endarterectomy and under general anesthesia. No, this is wrong. So
Why?
we'll go for it because anatomically and regarding the general anesthesia, patient is not fit, and she has high bifurcation anatomically, so surgery is not an option. So maybe I would choose A.
Yeah, I think it's a good choice. But the most important to be sure that they said to proceed within 1 week, because also again, this patient is symptomatic. You see, there's a risk, of course, that she may get a stroke, but the chance of stroke within 1 week is about 3%. So it's not too high. I think it's safer to do it this way. But if they said like to proceed after like 2-3 weeks, then it's be wrong. You cannot wait this long. Yeah. Remember, we said you have medication, you have to do it within 2 weeks to get a benefit. You don't want to wait long. So you have to be careful if you get in the exam. Loading patient with 150 is small. When they load it, they usually load with 300. So I don't know if it's a good option or not. But the safest way just to stop the surgery and give it antiplatelet for 1 week and bring her back and do carotid stent. This way you'll be stuck to the protocol. If something happened, you're already protected. You're working with the protocol, you know, criteria. Okay, yeah. Thanks, Sam. Amjad, you want to take the next question, Amjad?
Yes, hi, doctor. Yes, I want to take it.
Okay, let's see what that. Go ahead.
Okay, a 57-year-old man present with a right hemispheric transischemic attack and embolic in his right hand. CT angiography demonstrate a severe atherosclerotic lesion of innominate artery. This lesion extended from the origin where there is a dense calcified plaque to the mid-distal portion of the artery. The remainder of the ascending aorta and aortic arch are relatively non-calcified. The right subclavian and carotid artery are patent without hemodynamically significant disease. The left internal carotid artery has 70% stenosis. The most durable surgical reconstruction of this lesion would be. So this is 57 with the symptomatic symptom, CT showing stenosis in innominate artery, more proximally. With the patent arch and ascending aorta and carotid and ipsilateral, it's patent. However, in left side, internal carotid artery showing a 70% stenosis. The patient is symptomatic for this one, left side.
Okay, so we have an innominate artery lesion, which is embolizing to the two things, embolizing to the right arm and to the right brain, correct?
Yes.
The 70 and the other asymptomatic. It's nothing. It's just put it. We don't have to worry about that. So the problem we have an innominate artery lesion involving starting from the origin and going ascending. I think they said to the mid distal part of the artery. Okay.
Yeah.
And it's not the point. Didn't tell you stenosis, but looks as an embolic. So it doesn't matter how much the stenosis. Patient is symptomatic. So we have to deal with it. You know. So what options we have? Let me see what options they gave us. Okay, let's go one by one. Okay.
Okay.
Let's start first and I will say if it makes sense or not.
Okay. So left to right carotid bypass.
Okay. In this way, let me talk about that. Okay, if you do left to right, of course you have to ligate the common, because otherwise, if you do left to right, then you have to ligate the common. Otherwise, you keep embolizing from innominate artery, right?
Yeah, you didn't solve it.
Right.
Yes. Yeah.
That will
Sternotomy.
solve the no, still early. No, we didn't finish with this. So if you do left to right, you'll solve the issue with the right, because you're going to do bypass from the left to right. The right internal get blood flow. You ligate the origin of the right internal, the right common carotid artery, you stop embolization. So we'll solve this issue, but two things the problem with this one. First, you did not solve his arm because he embolized to the arm, correct? So you solve the embolizing to the brain, but did not solve the embolizing to the arm. So this is the problem with this approach, you know. And the second thing is that the left already has 70%. I mean, it's not contraindication, but I don't like to do bypass with the left 70%, you know. So there's other reason, but mainly things here is that you're not solving the issue with the right arm also. Okay. So let's see the next one.
Sternotomy and anatomy artery endarterectomy. I think it looks so aggressive.
Okay, but is it possible? Aggressive, but it's one of the options. Let's put it on the side. Let's see what the other option. Yes. When you go in the exam, you take off the very obvious wrong. So something is like, yes, put it on the side, then you let the end with a 2 or 3, you can pick one of them. So this one, yes, I mean, we can think about it. Let's go to the next one.
Left to right carotid bypass and right carotid subclavian bypass. So this one solve both presentation, the arm and the transischemic attack.
Yes, but the only problem, as I said, you have the left side of 70%.
Left side 70% stenosis.
So this will not be the best option, I think. Yeah. Next one.
Total aortic arch replacement.
Total aortic.
It's not related to arch. He said arch, it's normal, ascending and arch. So why we do it?
That means he wants to do a bypass to the total arch replacement. That means he wants to do a bypass to the innominate left common subclavian, which we don't need to do that too much because the lesion only innominate artery. So why you need to do bypass to the left and left sub? This is when we do the branching. So total arch replacement, that means bypass to all, but you don't need it because we have a problem only one artery. The other artery are fine. So this is too much. Will not. This is wrong. The last one.
Sternotomy and ascending aorta to distal innominate artery bypass.
Okay, so doing bypass from the ascending aorta to the distal innominate artery. Of course, you like it innominate artery, you know. It sounds difficult, so it's possible. So we end with two options, right? B and E. Both need sternotomy. Should we do endarterectomy or bypass? This is the only two options, right?
Yes.
But the other option doesn't sound right. I'll tell you what the problem is that. The problem is that they said, technical part, they said the calcified lesion at the origin of the innominate artery, right? So that means you cannot, if you're going to do the endarterectomy, you have to go to the origin of the innominate artery. So how are we going to control the aorta? Would be very hard because you cannot put a clamp on that, you know, they have to put a clamp on the arch itself, right?
Yeah.
Then you have to put patient on hard bypass because you cannot just clamp the ascending aorta, then become more complicated, you know. If you do just a bypass, then you just put a partial clamp, like when we do deep branch, you just put a partial clamp in the ascending aorta, and you do bypass from the ascending to the innominate artery. So technically it's easier and you don't have to stop the heart. So really, I think, this is the best option to do a bypass. And then you ligate, of course, the innominate artery, otherwise we'll continue embolizing, you know. But if the lesion was not at the origin, then no, sternotomy, then you clamp the innominate artery, then you do endarterectomy. But because it originated at the origin, then you have to open the arch, then become very complicated. And that's the reason why it's better to do just a bypass. Okay? Other option you can think about stenting. Didn't mention it here, but could be an options, you know. But the only problem with that is that embolization is a problem, you know, because you're going to embolize before you put a filter, right? Because you cross the lesion with a filter. So really, if you want my I think approach for this lesion, none of them. What usually I would done in this case, I would done a smear cut. I open the common carotid, I go retrograde, cannulate, put my wire through the arch and put a stent. And then I'll flush before, of course, the common will be occluded, so I don't get any embolization. Then I flush the common and, and just put a cover stent, I think this is the easiest way, but you have to do it from a common carotid and clamp the common carotid when you do stenting to prevent any embolization. You don't do it from the groin. And this is much easier because just straightforward, very straightforward cut, way. You don't have to go through the arch and because it's very hard to cannulate innominate artery when you have a disease artery or occlusion or severe stenosis. But if you go from the common carotid, right common carotid, it will be easy to cross it and just put a cover stent, flush the common carotid to prevent any embolization, and then you'll be done. Okay?
What about lesion location? It's amenable for stenting and orifice?
So yes, like subclavian, all of them flush occlusion. We do them all the time. The only problem with an artery is a big artery, it's a big. Also you need like 14, so you need a large stent. These are problems, So this is the only problem will be is to put a cover, but you're going to make a cut down in the common carotid, so you can put a big sheath and you can put a big stent. Other option, you can do 2 cover stent. You can go from subclavian, right subclavian, and from common carotid, and you go down and you put 2. If you don't want too big one, you don't have too big. Maybe you put like 2.8 or 2.9 cover stent. They coming like a chimney. They come from the arch all the way to the right common carotid and right subclavian artery. Okay.
And can we go transfemoral with the reverse flow instead of protection device?
See, the problem is not the reverse flow. The problem is that the moment you're going to do anything like reverse flow, because you want the reverse flow, you have to close the external carotid artery with a balloon. The problem is that anything you're going to do as a filter reverse flow, you have to close the region first, then you do that. So it'll be too late because you're already embolized. So any region at the origin of the common carotid artery brachiocephalic always we go retrograde, Like if you have a common carotid artery occlusion or stenosis, it's not safe to cut from the femoral. It is safer to make a small cut, go retrograde from the common carotid, do stent, flush it, get rid of all the debris, and then take it out. And it's much easier, just small change in the neck, and it's even straightforward case,
اسمع اذا قال لك تعالي شوفيها.
Thank you.
Bassam, you need to mute yourself, Bassam.
Sorry, doctor. Sorry.
Okay. All right. محمد.
معك دكتور، كيف حالك؟
هلا، شو الأخبار؟ تمام؟
الحمد لله، أبشرك.
Let's get 43. What number 43?
Okay. Bismillah. A 60-year-old woman is referred to your office for evaluation of innominate artery and left common carotid high-grade stenosis at their orifices with ulcerated plaques. The patient has history of pre-syncope right hemispheric stroke with resolution of the right hand weakness and left eye amaurosis fugacis. She has failed an attempt at endovascular revascularization. You recommend ascending aorta innominate artery and left common carotid bypass through transthoracic approach. The potential complication of aorta innominate artery bypass is okay. I think he answered the previous question, right? By the type of surgery.
Well, let's see. I'm sure they're going to give you a different option. I will see. I don't know. But you have a patient who has a stenosis in both innominate artery and left common.
Okay.
Symptomatics, both, right? Because I left eye amaurosis had right hemispheric. So you want to do a bypass now because he felt in the vascular, right? The vascular failed. So you have to do a bypass.
Yeah.
You have to do debranching from the ascending to the oldest artery. So they want to know what the complications. They're asking, not asking about the bypass. I think they know bypass. Because
they choose that surgery. Yeah.
So what the injury could be? Let's start one by one. What the most common or potential complication? Okay, let's start. So you're doing aorta innominate artery bypass, the same what we mentioned before.
Yeah.
What the potential complication? Okay.
So A is a hypoglossal nerve injury during dissection of the proximal subclavian artery. This is very, the location of hypoglossal is a little above that, above subclavian. So a chyli leak due to injury to the thoracic duct. If you approach, yeah.
Just wait one by one. Don't rush.
Okay.
The first one, hypoglossal nerve. When you see hypoglossal nerve injury,
if we are working in carotid, I can.
Okay. So this is too high.
Yeah, it's
the subclavian artery. What do you think it could be? Because I'm sure it's another nerve, because otherwise they not put the nerve. But they put the
usually you injure here the phrenic.
Okay.
And sympathetic change, Herner syndrome.
Okay. This is correct when you do cause subclavian bypass. Correct.
Yes.
But this is mainly in the second and third part, you know. Even the proximal, you can get it. You're right. But the thing usually, if you remember, if you're doing thyroid surgery, you know, where is the recurrent nerve? It's close to which artery? You remember?
Recurrent, recurrent coming with recurrent coming with inferior thyroid artery.
Which is branch of what? Subclavian artery.
Yeah, subclavian artery. Yeah. With the superior. Yeah.
So this is one of the recurrent nerve is one of the injuries you can get from subclavian artery if you go really very proximal.
Yeah.
Okay.
Yes.
Okay. So next, and Horner syndrome, as you said, yeah, sympathetic also could be damaged. Yeah. Next one.
Next one, chyli leak due to an injury to the thoracic duct.
Okay.
Yes, if you're working in the left side, yeah, you might injure it.
Here we are working on the right side, so this is wrong.
So no, yeah. So neck and facial swelling due to ligation of left brachiocephalic vein.
Okay. Usually don't have to. Why need to ligate it? You know. But even if you ligate it, venous system is very, a lot of collaterals. You can drain through the other one. Many times you see brachiocephalic vein is occluded, and if the SVC is open, you don't see head swelling. The only time you see head swelling if you have IVC occlusion. But if you have only one side brachiocephalic occlusion, usually the contralateral will be more than enough. So even ligation or thrombose, one brachiocephalic will not cause facial swelling. So this should be okay.
So pericarditis due to opening of the pericardium?
I don't think so. I don't think
so. Yeah.
Never saw that, something like that. Okay.
So compromised graft patency due to graft compression during the sternal closure.
Okay. This is only one left, so it has to be. I tell you, this is correct. The first time I did a debranching, I didn't pay attention to this one, so I put the graft on the anterior aspect of the ascending aorta. And when we come to close the sternum, I noticed that it's compressing the graft because it's very narrow space between ascending aorta and the sternum. So why when you do debranching, always has to be on the right side of on the side of the ascending aorta. Never do it on the anterior aspect. So if you do it on the anterior aspect of the ascending aorta, you may compromise flow by closing the sternum. So it's always, when you do bypass, remember that always put on the side of the ascending aorta. The reason why these ones are correct. Okay?
Okay, great.
All right. Maitham, are you here, Maitham? I see your name. Maybe not. Okay, Sam, you want to take it?
Yes, sir. A 60-year-old man presents with thoracic aortic aneurysm involving the transverse arch. In order to obtain sufficient landing zone for a thoracic endograft, a deep branching procedure is proposed. When comparing transthoracic supra-aortic trunk reconstruction to cervical extra-anatomic approaches, transthoracic approaches are historically associated with.
Okay.
So,
What I need is
okay. Yeah.
Like if you have to do deep breath, if you need landing zone, you know.
Yes.
So either one option to do like carotid bypass or carotid subclavian bypass called extra-anatomical approach, you know, because like you want to cover subclavian or left common carotid, you know, then you do carotid bypass or carotid subclavian bypass. Okay, this is one which you can do, or you can do a deep branch from the ascending aorta to these arteries. Okay.
Yes.
So now they ask you which one is better. If you compare extra-anatomical approach, which is carotid or carotid subclavian, you know, bypass to ascending aorta to this branch, like debranching, you know, which one is better? You understand the question?
Yeah, extra-anatomical, or something without sternotomy.
Sorry?
Either without sternotomy or with sternotomy. From the arch or extra-anatomical from the neck.
Without anatomical is the neck. Opening sternum, this is an anatomical location. Yes. Like when you do iliac femoral, this is not extra-anatomical because it's a normal location, right? When you do a iliac femoral, this is extra-anatomical. So carotid is extra-anatomical. But ascending arch to the carotid, this is normal. This is a bypass, you know?
Yeah.
I want to tell you which one better, to do a bypass from the ascending aorta to the carotid or subclavian or brachiocephalic, or do carotid subclavian bypass. This is a question. To open the neck in only or opening the sternum.
Yes.
Well, the neck is better because it's smaller, but of course there is a price going to pay because sternum it's more invasive, but most probably it's better graft and larger graft, you know. So most probably it's better patency, you know. So we'll look. Let's see what options they give us.
Okay.
So they're transthoracic. Transthoracic comparing with the
extra-anatomical. Yeah, lower risk of stroke.
There's no difference between both because the same. You're going to clamp the common carotid in both sides, either you do or ascending. Even though it could be the stroke higher because you clamp the ascending aorta when you do ascending to carotid bypass. So it's not lower for sure. So it could be either the same or even more with that thoracic carotid. Yes.
Okay. Lower risk of pulmonary complications.
Not different really because you don't open the lungs. You sternum and the neck. We don't open the chest. So it should be no different really between both.
Mm-hmm.
Okay.
Okay. Higher patency rate. Yes, you said before.
Usually in general,
لما تكون أكبر. Yes.
Not only akbar, it's the direction. Like the same when you do like, you know, and become shorter, you know, not really shorter because carotid is short. But in general, when you do bypass with the direction, I think you get better patency than when you do extra-anatomical bypass.
And the flow will be stronger لأنه جاي من الأورطة directly.
Correct. Okay.
Okay. Lower risk of myocardial infarction.
They should be higher because you're working close to the heart, you know, or could be similar. This one could be similar or higher, but not lower for sure.
Okay.
More invasive procedure, right?
Yeah.
Okay.
Lower risk of mortality. Oh, the risk of mortality with thoracotomy is more than the extra-anatomical.
Correct.
So yeah, we'll go with C.
Which is a better patency.
Yeah, higher patency.
I think this is I think the most reasonable things, you know. Okay. Well, let's go to the next one. 45. We'll go back to you, Amjad.
Yes, doctor.
Okay.
A 76-year-old man with a large penetrating aortic ulcer presenting in consultation, perioperative imaging, varies the focal pathology and associated arch morphology. specific to this patient with the thoracic aortic disease, which of the following is a correct description regarding the type of aortic arch that is seen in this image? So he's asking about the type of aortic arch in this image. I think this is type 2.
Can you remember was the type 1, type 2, type 3?
Type 1, all of them. Yeah, type 1, all of them will be in the same level. Type 2, two of them will be one of them another level, and two in same level. And type 3, each branch in each level, separate level.
All right, this is one way to do that, correct? There's another way, what some people they do, because it's different, school. They look at the innominate artery, okay? Innominate artery at the level of the, because if you get to go, what's going to go lower is innominate artery. It cannot, left common carotid artery cannot be lower than innominate artery, correct? So when innominate artery at the level of the outer curvature, that means all the same level, the same what you're saying, but just the way they visualize it, So they look only at the innominate artery, because innominate artery reflect all of them, Innominate artery at the level of the aortic, the outer curvature, this is type 1, okay? If between the outer and inner curvature, this is called, if it's type below inner curvature, then it's type 3, okay?
Okay.
And so you may hear it different way, just so you know both way how you do it, So this looks like type 2, correct?
It's look bovine arch also.
And bovine, correct. It's a bovine and type 2 arch, okay? Okay. So what they want to ask? Let's see what the question is. Sorry. Here we are.
Yes.
Sorry. It's going too fast. Come on. Where we are? Went too fast. I know where we are. Sorry, guys. My computer, it's not responding with me. Question? Yeah. Okay. All right. Let's go to the first one. This is
type 1 bovine arch.
Is this type 1? No, is this one type 1 or type 2?
It looks like type 2, honestly, in the image.
Okay, let's go back. Let's see why it's not type 1 and type 2. Okay.
Okay, if we put 2 lines,
second line, correct? So it's not in the same level. One and the other one is here. It's not the same level. This is if you go with the other classification. This is the inner curvature. This is the outer curvature. So it's between. So it's type 2. This is type 2. So it's a bovine. Okay.
Yes.
We go back to the answer. They said type 1 bovine. This is wrong.
Yeah. Yes.
Present in 25% of the cases, bovine. We don't know. So we keep this on the side. Could be because you don't know the answer. Could be because I'm sure you can't remember the number. How often, what's the percentage of bovine? We don't know. So in the exam, you don't.
Most common variant, I think it's bovine among aortic arch variants.
30, is it 40? I mean, unless if you're really 100%, you answer. If you don't know, put on the side and go with the other question.
Yeah.
Okay. More common in elderly. Usually they are more common as type 3 because they get a more curve,
Yes.
So usually is not really all people. Okay.
Rarely associated with bicuspid valve. Rarely associated with bicuspid valve. I think it could be.
Okay. Is a bovine, usually they found the bovine arch is really associated with bicuspid valve.
Bicuspid valve, yes.
It is, but it's not rarely, So this is okay.
Less frequent with the thoracic aortic disease.
Okay. I don't know. I mean, this is what I'm saying. You have to read about bovine arch, you know, but less frequent with the thoracic aortic disease. Not really. We see it quite often. You can see when you deal a lot of aortic aneurysm, we see both common. So it's not really less frequent. So again, this question you have to read about bovine arch. That's 25%. So maybe this is but this is the most, as you said, this is the most common, you know. Just have to read about it, okay? Okay. It's not a very good question. Let's go to the next one. I think the question, if they ask you what type 1 or type 2 or 3 would be better, you know, than ask you what the bovine type and, you know. But always remember, bovine is associated with a bicuspid valve. This is an important, you know. And this is the most common variant as you said. All right. Hamad?
Yes, doctor. Number 46. A 65 years old man presents with ataxia and cortical blindness. MRI reveals posterior circulation strokes. Computed tomography scan showed an 80% of atherosclerosis stenosis at the origin of the left vertebral artery and approximately 40% stenosis of his right carotid artery. The left internal carotid artery is normal. Despite optimal medical medication, he has recurrent attack of symptoms. The most appropriate management for this patient is so posterior circulation with the combined of less than 50% stenosis in the right carotid artery, and he's already on medical treatment, not improving.
So where the symptomatic, which one is the symptomatic? What we have here, which one symptom coming from?
The symptomatic is the vertebral artery.
Left vertebral artery. All the other things is useless, whatever they said. So we have 80% at the origin of left vertebral artery, V1. We have a severe stenosis, okay? Yes. When you have carotid stenosis, like a TIAs, you know, always we try to treat it conservatively first. It failed with the medical management. So you have to do something for that, you know. The best treatment for carotid stenosis is either you do transpositions or you do stenting. I mean, the new guidelines, they advise to do stenting for common carotid artery, you know. But still people, they do transposition or bypass, you know, for the V1. The first part, you know.
You mean vertebral artery, not carotid.
Vertebral artery.
Yeah.
No. This is 40% asymptomatic for carotid. All these symptoms are posterior circulation. And we have 80% stenosis the left vertebral artery. So, so why he put this? Because he wants to tell you that the carotid is not, you know, is a problem. His symptom from the vertebra is carotid, you know.
A kid, yes.
So let's see what options they tell you. It's the one by one and
continue antiplatelet therapy and observation.
Okay.
Patient is symptomatic and he get quite a good time in that treatment. Yeah.
Ahmad, you see, that he, despite optimal medical management, he's still getting has an attack of symptoms. So why need to continue? It's useless.
Yes.
And optimal medical management. They did an excellent medical management, and he's still getting symptoms. So continue. This is out of question. I mean, that's you have to do something more aggressive now. Okay.
Yeah, sure. Endovascular stent placement into the right internal carotid artery. We got symptoms from the vertebral artery and posterior circulation symptoms. So I don't think this is the option. It's not the option.
Because right carotid is asymptomatic and it's only 40%. The only 40%.
Yes.
Forget about it. So no, this is wrong.
See, endovascular stent placement into V1 segment of the left vertebral artery.
Okay.
yes with this.
Okay.
And D, right carotid endarterectomy with patch angioplasty. No. And E, left vertebral artery transposition to common carotid artery. So we have C and E. Both are option.
Is a bad question, because in my opinion, C is correct. You know, because the guidelines, the early guidelines, they said C. Now it's the first choice. You know, it's for vertebral stenosis, stenting. But also transposition is not wrong. You can do vertebral transposition. You know, the most appropriate management. You know. So this is a problem. Sometimes some questions, they're not really smart questions, you know. Let's see what they said here. You see, they choose a bypass, you know. Why is that? Let me see. Endovascular stent may be an option, but large study compare open to endovascular therapy are lacking. Additional longer-term theoretic may be an issue with higher rate of restenosis or stent fracture. At present, this procedure should be reserved for selected patients. Yeah, I don't agree with 100%. So if I mean the exam, most of it I'll be putting a stent, you know. But mostly they're going to mark me wrong for that. But anyway, so this way you have both options. But again, if you go with the guideline now, it's the stenting is the guidelines. But also you can do a transposition, you know. So I think both options are valid. Okay.
Okay, great.
Let's go. Yeah. Okay, let's go to the next one. We said that, right? Yeah. Who's next? Bassam, we can back to you, right?
So
my computer is slow. Let's take 47. Stop. Okay. Okay, go ahead, Sam.
A 59-year-old man presents with an episode of acute onset dizziness, loss of balance, and transient syncope. MRI shows a small acute impact in the cerebellum. A CT angiogram demonstrates no significant occlusive disease in the great vessels, less than 50% stenosis of the bilateral internal carotid arteries, and a focal 90% stenosis in V2 segment of the left vertebral artery. He is an acceptable surgical candidate when considering vertebral revascularization in this patient. The most appropriate treatment plan is, so in summary, 59 years old, presented with posterior symptoms. I think it's related to vertebral artery, not related to carotid. And he's for surgery.
Correct. But the problem is the V2. Let me tell you what the vertebra, if you remember. We call V1, 2, 3, and 4. V1 is from origin until it go to C6 when it go through the neck, the spine. Okay. V2 is a segment inside the spine, the foramen. You know. V3 when he comes out from the spine to the base of the skull, and V or dura, and V4 when become intracranial. Okay. So V2 is the part inside the bony structure of the cervical spine. Okay. Yeah. So, and if you want to do any bypass, always either you go to V1 or V3, because the only two parts are acceptable. V2 is inside the spine, and the V4 inside the brain. So anything you have to do, it should be V1 or V3. Okay. Yeah. You understand it, guys?
Right. 1 or 3.
1, yeah. 2 is inside the bone, 3 out, and then 4 go inside again. So let's see what options again. So he lesion 90% inside the V2, which is inside the bony part, you know, it's 90% still. and he's symptomatic. So how can we deal with that? Let's see what the option. Let's start one by one and see if it makes sense or not.
Okay. Selective catheterization and coil embolization of the left vertebral artery. So that means we'll occlude it.
Yes, and I tell you, this one could be because I saw that they do it here in King Faisal. I saw a couple patients, they're bleeding from the vertebral artery, or they have an fistula. They go on and coil embolize the left vertebral artery. This is a possible this way, but again, you have to be sure it's not the dominant artery because you may end with a stroke.
Yeah.
And second thing, always the chance that if you clot it, the clot may move to the brain and cause a stroke. So I don't think the best option, even though some people they may do it, but I don't think it's the best option. This is the most appropriate treatment. It's not the most appropriate. It could be one option, but it's not the best option. Okay.
Okay. Left vertebral artery end arthrectomy. Yeah, V2 is almost difficult. Not doable. Yes. So it's not a correct answer. Transposition of the proximal left vertebral artery into the left common carotid artery will not solve the problem because the stenosis is inside the spine.
That is the V2. So if you do transposition, this is good for origin, but not for V2. It's good for V1.
Yeah.
Correct?
Yes.
That's wrong. Okay.
Transposition of the distal left internal carotid artery end to end into the distal left vertebral artery. Wow, it's a big surgery, but yeah.
And then you sacrifice the internal carotid. I mean, who's going to do that? You cut the internal carotid and you suture the vertebra. What if you get a stroke? What if it's the left internal? This is dominant, or it's the main, he has not, sacral force is not intact. So if you transect the internal and you ligate the distal internal to do internal to vertebra, then you make a stroke on this side, right? Because you sacrificed internal in one side. So it's not a good choice. No.
It's not an option. Okay, left common carotid to distal vertebral artery bypass with reverse grade saphenous vein. Well,
I think it's the only one.
Yeah, it's okay. But يعني it can be done by vascular surgeon ولا بيعملوها neurosurgery because it will
I never did it. I never saw it. I don't know. I know, must be that, but I don't think it's a good. This is also not a good question for me. If this happened, it's for stenting. I think I sent to neurointerventionist, and if they can stent the first part, they cannot stent the second part.
Yes.
So in these days, I will just send him for stenting because this is a major surgery to go from the left common to the V4-3. So it's easy to say it and write in the book, but reality is tough. I never saw it. I never did it, so I cannot comment. But between all of them, this is the best answer. Yeah. Okay.
Yeah. Okay.
All right. So the next one. Today it looks all vertebral artery today. 48. Amjad, you want to take it?
Yes, doctor.
That's a short one. It's good.
A 76-year-old woman undergo transposition of left vertebral artery to the common carotid. The most common complication of this procedure, the transposition of left vertebral to the common carotid. Most common complication. Choice meiosis Horner syndrome can be from sympathetic change injury, posterior circulation TIA and stroke also can be. Hoarseness due to recurrent laryngeal nerve palsy. Hoarseness, recurrent laryngeal nerve palsy, also disability.
Possible, okay.
Lymphocele, yeah.
If you end the left chylon, correct?
Yes,
okay.
Exactly, left thoracic duct. And hematoma, all of them, it sounds correct, but the most common.
So the one to must be this is a question also, because really it's confusing. For me, it's all of them is correct, But which one the most common? the one you have to flip the coin. I think the Horner syndrome is the most common, but I think, as I'm saying, it's all complications. That's all you have to read the paper to which ones they found the percentages higher. Let's set here.
Horner syndrome, most common. Okay.
Most common reported, you see, of maximal, you know. But for me, really, from the practical standpoint, the most problem I saw Horner syndrome. I never saw Horner. I saw chylus leak is the most, in my opinion, is the most. Because if you have to do transposition, you have to go really deep, and you can injure, especially on the left side, the thoracic duct, and you can get the chylus. You know, you can see in the surgery. I mean, yes, it does, but every time we do, even you see like whitish, you know, material coming out. It's not a major injury, but all the time we injure him. So in my opinion, I think the lymphatic leak is the main problems. But if you go to the paper, I think is they said is a Horner syndrome. But anyway, there's a good question about this question to know about the complication. All this complication could happen, okay? All right. Well, let's go to the 49. Muhammad?
Yes, doctor. 49, a 75-year-old man presents after posterior circulation stroke. As part of his workup, a CT angiography of the head and neck was performed and demonstrated no significant carotid stenosis, a dominant right vertebral artery, and a 70% stenosis in the left vertebral artery. Prior to his stroke, the patient was compliant with antiplatelet and lipid-lowering therapy, including statin. Endovascular management of the vertebral artery stenosis is associated with.
Okay. See, this question, they contradict themselves. That's why I told you it's bad questions before. You see, here they said you have to do a stenting, right? They didn't do carotid transposition. You see? When we answered the first question, when it was choice between stent and transposition, they used transposition, you see? Just tell you how is bad planning or these questions. But again, I mean, this is really what we do usually. The first choice is to do endovascular management, is to do a stenting of the vertebral artery, okay? So the question now is that if you want to, about stenting, let's see what the question are. Let's go one by one and see if it makes sense or not. First one.
Okay, a high risk of symptomatic embolization without a distal embolic protection device. So,
okay.
So we needed to do.
Do we use embolic when we use vertebral artery?
Usually, no, I don't think so, because there is a reverse flow, right?
No, not really. Because artery is small.
Yeah.
You know, very small, and again, the problem also the ambulation, everything. But I never saw somebody using embolics. You know, the problem is that the experience with the vertebral stenosis, not many. Don't see like many papers. But if you see people who do a lot of vertebral stenting, I never saw any of them using embolic protection device, you know. So it's high risk of sympathetic embolic without distal. This is wrong, because I don't think it's a high risk. Otherwise, other one will use it. Like in the internal, when they start doing internal, they use without device, embolic, but they have a higher chance of stroke. The reason why is they move it and they make it as a standard. In the vertebral, I think the risk of is not too high. The reason why it's not a standard to use an embolic protection device. Even if you go to the guidelines, nobody said to use an embolic protection during vertebral intervention, okay? So this one is wrong, okay?
B, higher peri-procedural stroke rates compared to carotid artery stenting?
Not really. Not the stroke is not higher than with a carotid artery, so this should be also wrong.
C, endovascular intervention is superior to best medical therapy?
That is the best medical therapy. I think not really. I mean, none of them showed this better. You see, always we saw the best medical therapy. If it failed, then we go to endovascular. Endovascular is not our first choice. Always when we have carotid stenosis and symptomatic, always becomes the best medical treatment. If they fail, then we go endovascular, because no study showed that endovascular is better or medical treatment is better. So none of them are superior; they are equal. So this should be wrong. Okay.
The endovascular intervention is associated with higher risk stroke rate than best medical therapy. هذا أتوقع نفس الجواب اللي فوق ولسه or not. So recurrent symptoms are the most common complication. I don't know about vertebral artery stenosis, but anytime in endovascular, I think this is an issue, recurrent of the symptoms. You know?
Yeah. Yeah, I think there's only one left.
Yeah.
Wrong. So this should be maybe the answer. Recurrent symptoms are the most common complications. I will not call it complications because symptoms will not come right away. This is come later on, and it's not complication. It's stenosis. But I think same thing doesn't make sense. But because you do the other one, then it's the only one left. You know. I think you have to go with this one. All right, it's the next one.
No.
Oh, let me see. What
they put here. The protection device, doctor.
No, it can be. Let's go and read it. You know, it can be. This failed to demonstrate superiority in meta-analysis study looking at the vascular vertebral artery symptoms are the most common complication. See, and stroke rate were uncommon at less than 2%, in spite of the fact that most interventions do not use an embolic protection device, and find it has limited use given the size of the most vertebral artery. I think the guys who wrote there is wrong. So no, the answer for this one will be it's recurrent symptoms, okay? Because as this protection device is not required in vertebral artery, you know? The same when you do intracranial intervention, nobody uses protection device, right? You can go to a neurointerventionist, they do all intracranial lesions, none of them they get protection device. Because protection device is large and need big arteries, you know? They don't work in small arteries, you know? And the reason why you don't use them in the renal, you don't use them in the coronary, even though they could embolize, but the size is small, you know? Okay. All right, so this is answer. Let's go to the next one, 50. Bassam.
أيوة.
Let's go.
Yeah, let's go. A 45-year-old woman is seen for a large pulsatile mass at the left neck. Duplex ultrasound demonstrates a 4 centimeter hypervascular mass at the carotid bifurcation. CT angiography notes a hypervascular mass at the carotid bifurcation that encases the internal carotid artery, which is consistent with a carotid body tumor. The contralateral carotid artery is free of tumor. Serum catecholamines are normal. The most appropriate management of this tumor includes. This is an easy question, easy question. But usually it's not a pulsatile mass. Yani it can like transmitted. Yani pulse can be transmitted, but it's not pulsatile mass.
But anyway, it's right?
Okay. Observation. Okay, no need for observation. It has to be resected or treated. Radiotherapy. No, it's not the first line. Embolization as primary therapy. Embolization alone, I don't think so, no. Preoperative chemoembolization. Chemoembolization, yeah, we have, sometimes we do embolization. Balloon occlusion test and embolization, but
chemoembolization.
Chemoembolization. No, it's we do. والله اصبر خلينا نشوف. Preoperative, we test the we do occlusion test and embolization, but not chemo. كيمو يعني زي alcohol or something صح ولا؟
Chemo, no. Chemoembolization is a chemo. This part of the now is a new treatment of the tumors. If you have a cancer,
chemotherapy يعني? No.
but they give it
No,
inside.
no, it's not.
Because it's a tumor, they want to confuse you that it's a tumor, you want to treat it with a chemoembolization. This is what they try.
So no, it's not correct.
Yeah.
Okay, embolization followed by resection. Yeah, this is the usual treatment.
That's it, you see? You graduate. Great.
Okay. Yeah, thank you.
All right, let's see the last question. We finish this section. I think it's one more question. Yeah, here, 51. Amjad.
Yes, doctor.
Let's do this one.
Okay.
The all correct.
Okay. A patient presented with asymptomatic in-stent stenosis of carotid artery stents noticed in duplex ultrasound. The statement that most accurately reflects the optimal next step in management of this lesion is, so they're talking about asymptomatic restenosis, in-stent stenosis for carotid artery.
Carotid artery stent and asymptomatic in-stent stenosis.
Yes. Duplex ultrasound. Yeah.
Usually the guidelines, they said if you have in-stent asymptomatics, usually we leave it alone.
Leave it alone, yes.
I'm very severe, I'm afraid that sent me thrombosed, then you do re-stent it, you know, or you just balloon it. We don't do surgery, it's very difficult because stent go all the way along and to extract it is very hard, so you end up doing carotid, you know, replacing the internal carotid artery, so it's very complicated. So carotid stent treatment, symptomatic, you have to re-stent it or balloon it or do a surgery. Sometimes if symptomatic, then either you can do surgery or re-stenting. But if it's asymptomatic medical treatment, let's become very severe and worry about, you know, occlusion, then you may touch it with a balloon, okay? Okay, let's say what the...
Okay. Confirmation of stenosis with a CT is needed before treatment. We said it's asymptomatic, so we don't plan to do a treatment. And I think ultrasound as image will be enough.
Okay.
No need to do CT.
Okay.
The redo carotid stent is superior to endarterectomy. It's asymptomatic, so no intervention.
Yeah, it's not superior to endarterectomy. I mean, it's better. I know the problem is that sometimes make a sense, but maybe we don't have a data to say. Like, I mean, redo carotid stent, of course, is easier than endarterectomy. First, you don't do endarterectomy. This is a mistake because if you have to go there, you replace the hole. Not you endarterectomy with a stent. So this is a problem with this question. When you do redo carotid stent superior to like resection replacement, then it's different, but not endarterectomy. It is wrong. Okay.
Analyze the stroke risk is greater than de novo atherosclerotic stenosis. We said the pathology is different. It should be hyperplasia. So I think with atherosclerotic will be higher, the stroke risk.
Correct.
Contralateral occlusion does not influence management. I think it's influenced the management.
And it's also could be both ways. Yes, if contraocclusion, then have stenosis, depend. Like 30, 40%, I will not worry, but become like 70, 80, 90%, I may worry about it. Was my management. But again, I mean, this question is not great, really. Let's say the last one.
Drug-coated angioplasty is superior to redo carotid stents.
This is
in the data. In any data supports use of drug-coated balloon and carotid?
No, we don't have any data, so we don't use it in carotid, you know. So all of them is wrong to me.
If I go with the most reasonable one, it will be A. I'm not sure.
It is needed. Yeah, I think it's the most reasonable one, but it's a bad question. I don't like it. Yeah, but that doesn't make sense. What confirms stenosis CT is needed before treatment? Before treatment, if you decide to treat in the future, but we're not going to treat it now, you know? Anyway, I don't think it's a good question, you know. Okay. I think any more questions? Let me see if any more questions. No. So before we go, let's go review the guideline before we go. Okay. Could just be sure that we got the right information. Okay. Let's go to the carotid, vertebral, and all the things. Let's see what the guideline said. So in this way, we can fix our informations. Surgical technique, redo intervention after carotid. Okay, let's see here. Patient suffering from late ipsilateral TIA and presence of ipsilateral 90% should undergo redo carotid endarterectomy or carotid stent. When there's a patient suffering ipsilateral stroke. Oh, sorry. Here. It's recommended that carotid stent patient who develop asymptomatic more than 50% are treated medically. Okay? Guys, you hear me?
Yes, doctor, but we cannot see the screen.
Oh, you tell me that.
Oh.
But you see me. How I can fix that? Let me see. You share. Yeah, here we are. See it now?
Yes, doctor, clear.
The lecture we talk about in the morning, before when we start, about redo, carotid, and everything's an important slide, you know. If patient has a stroke and he has 50 to 90%, you have TIAs and restenosis after surgery, then you have to do carotid endarterectomy or stent, okay? If symptomatic less than 50 is a medical treatment, okay? If he has a carotid endarterectomy and asymptomatic, 70-90%, then it's multidisciplinary team review. This is after carotid endarterectomy, not stenting, okay? So patient had carotid endarterectomy, has 70-90% restenosis. Should we do it or not? You do multidisciplinary team. But if we go to if we go to carotid stent, if asymptomatic and stenosis more than 70%, is it medically treatment? Okay?
Clear, doctor.
Go to the vertebra. Let's see what vertebra. Common carotid stenosis, we talk about it today. If it's asymptomatic, leave it alone. If patient has most proximal common carotid and innominate should be considered for treatment via open retrograde angioplasty and stenting. Remember, we talk about it. So if you have a common carotid innominate artery, the best way is to do it is not what they said to do, bypass, whatever, to go and do an open retrograde. You open the common carotid, you go retrograde, and you do angioplasty and stenting. All right. Here's the vertebral artery. Asymptomatic vertebral artery sclerotic lesion should not be treated by open endovascular. Okay. Patient with recurrent VB symptoms who have 50 to 99% extracranial VA stenosis may be considered for revascularizations. When extracranial vertebral artery stenting is being considered, drug-eluting stent should be considered preferred to the bare metal stent. Okay. After that, you have to put patient on dual antiplatelets. Combined carotid and vertebral artery revascularization is not recommended to do the same procedure. I think that's all. All right, guys.
Doctor, one question. Stenosis over a stent, we should resect all the carotid artery and do great saphenous vein.
Bypass, yes.
Yeah, bypass. Okay, great.
Re-intervene on stenting for some reason. I don't think it's not, but for some reason you do ballooning, it doesn't work, or afraid you may embolize. You have a severe stenosis, then yes, the best way recommendation to resect this part and do carotid
interposition graft.
Yeah, that is why if you look at all our carotid stent are very short, 3 or 4 centimeters maximum, you know, because you don't want to put a long one and they become very difficult to take it out, you know. But most of them 3 to 4, most of the time you can take them out.
Clear. Thank you, doctor.
More questions? All right, so then we're done with this is a bit dry, you know, subject, but it's important, a lot of data. I think it's very common to see it in your daily practice. So hopefully you get a good idea how we deal with most problems. Next week we'll start with a new session. I don't know, I'm going to go with the VESAP, see what the third session is, and we go from there. Okay. All right, guys, have a nice day or night, and we'll see you later on or next week.
Thank you, Doctor.
Thank you, Doctor.